Oh, right and early, too early.
Yeah, welcome
Are you folks
to.
having the lockdown the same in Los Angeles? Are you guys
Yeah,
having
the same,
the
the same.
lockdown too?
Yes, yes. Till the
Same.
till the 3rd of
So
May. Yes.
nobody is working. Nobody
Nobody.
is making money. Everybody is poor. Yeah, it's really difficult here actually.
Yeah, yeah.
Lots
We are
of people
waking
lost
up,
their job.
waking up, and waking up and sleeping at all odd hours. So it's
Yeah. So is it pretty much the whole India is like this? The whole India or just
no
certain
whole
parts?
the whole of India.
Oh, India. That's really difficult.
Yeah.
That's
It's
extremely
it's
difficult.
very less people. 1.3 billion only.
Oh my goodness. Yeah, that's difficult. So
we
you folks, where are you folks located in Delhi or where you guys at
Yes.
in Delhi?
Sandeep Allahabad and
yeah.
Vaibhav Allahabad. I'm in Delhi, and Govind is
I
in.
see.
So we are going to start the session. It's already 8 o'clock, and
Okay.
good morning, India. We are here with the legend, Professor Joseph Khan, and we are really proud and we are privileged to have him here in the studio. And today we are going to talk about how he has achieved this pinnacle in his career to become a living legend in the world of implant dentistry, and especially anterior aesthetic zone. When we talk about anterior aesthetic zone cases, we cannot think cases without taking the name of Professor Joseph Kahn, because his Kahn's classification is one of the um, biggest, uh, the most important thing one has to have in the consideration when we are talking about anterior aesthetic zone placement implants. So let me say a few words about him, because if I start telling something, it will take whole day long. He has so much he has achieved. Dr. Khan completed his prosthodontics and implant dentistry from Loma Linda University School of Dentistry. He is a professor and maintains a surgical prosthodontic practice. He's on the editorial board of the International Journal of Periodontics and Restorative Dentistry and the
Alhamdulillah.
European Journal of Aesthetic Dentistry. Dr. Khan honors include the 1997 Best Research Award from the Academy of Osseointegration and the 2003 Judson Hincke Award from the Journal of Prosthodontic Dentistry. And he is on the guide panel also. He's one of the mentors for a guide program. And now I will request Professor Joseph Khan to say something about his life, to so that we are all we come to know about, we get enlightened that about his uh, the journey. So,
Okay, so good morning, everybody in India. Good morning, India. Okay, it is actually in the
Namaste.
evening in Los Angeles here. It is my privilege to be invited by you folks. We've known each other for a few years now, and you folks always been really kind. So I want to thank you for inviting me to this webinar here. Well, basically to say a few things about myself, I'm originally actually from Hong Kong. So I moved to the States when I was around 13 years old. My father's a physician. And obviously in those days, back then, They're worried about the change of guard from British colony to the Chinese government at that time. So they decided to move me to the States to study. And basically, I started my journey going through all my education, most of my education in the States there. Doing dentistry, actually, I never thought about specializing. When I finished my dentistry, I just actually want to, open a practice and do some dentistry. I have no intention to be an international speaker at all, and actually have no intention to even be known. It's just that I think I maybe fortunately enough to did a few research, publish it, and people recognized it. And somehow here I am, end up to be on the podium there. Basically, to put things in a nutshell, I mean, it's really kind for you to say a lot of nice things about me. But the reality, once again, is even at this stage, I really truly have no intention to be famous or known. I just want to do dentistry. I do research, mostly is just for my curiosity, to satisfy my curiosity. I don't do research to prove that I am correct. I'm actually to do research to prove what I do is incorrect. All right, that's what my intention always. And then in terms of career-wise, I've been really blessed that I'm involved in education too, besides private practice. And I think my graduate student pushes me to keep me going. All right, so here I am. I want to thank you all once again, India, for all your support and all my friendships that I make over there.
Thank you so much. Let me tell you, we have Dr. Lanka Mahesh here with us. He is the moderator of this session, and then my team, Dr. Vaibhav Gupta, and Dr. Govind Jha, and Dr. Chakshwesh, and Dr. Deepak. So this is the team which we have at the Sahaj Dental Academy, and I'm a big fan of yours. And I believe we met in SEPA 2 years back. Lanka was
That's right.
there with me, and Dr. Praful Bali was there, and Lanka presented you his book, which he had recently released, and it was a wonderful moment. So I will now ask Lanka to come over and start the discussion regarding dentistry. Hey, Lanka, over to you.
The first and foremost question that comes to everybody's mind when they hear your name, Joseph Khan, is the anterior aesthetic zone. And over the last 20 years, having seen and worked with a lot of people all around the world, first of all, I would really like to thank you for all your contribution towards implant dentistry. And people really look up to you. Your humility is what makes you apart from all others. I think you're a very humble person, and despite all your achievements. First question that comes to my mind is, if we look at your classification, sagittal classification 1, 2, 3, 4, if you have to treat a class 1 with a small fractured plate, a very small fractured plate, maybe because of your extraction or because of some existing trauma, what is usually your take? Everybody talks about GBR, over-contouring with an autoxenograft, or doing a dual zone grafting, or doing a socket shield. I know you have published on the proximal shield, but or the socket shield. What is your first? I'm talking only about a class 1 where everything is good, everything is fine, bone is intact, your soft tissue is fine. Maybe just a small fracture at the cervical third. What would be your delayed placement or immediate, or would you do a socket graft and wait with the Maryland temporized bridge? Let's say the patient is 25 years old.
Well, basically, as you know, if a patient comes to your office with a front tooth that's failing, you can do, option can be like an immediate implant placement. We can do an early placement. We can, in fact, extract and graft and wait and do what you call delay placement. Reality is, first of all, our tell you, there's no such thing as one method that fits everything, all right? And people may have feel that I have published a lot on immediate. To be honest, I've done quite a bit of early placement too, and I've done a tremendous amount of delayed placement. And so I'm not stuck into, I have no one such thing as my principle. There's no such thing as that. So on an anterior situation, young patient, failing tooth, buccal plate, pretty much intact, but maybe just a little bit compromised. I would definitely, if the patient desire, I would try to go with immediate implant placement. How critical it is to have a complete intact buccal plate? Well, our research has shown, and others also has shown over the years, that buccal plate is not as critical as what we think it used to be. As long as the buccal plate, the defect doesn't encompasses that of the adjacent teeth, all right? So that means if it's a limited defect, as long as it doesn't encompass adjacent teeth, we want to go for immediate implant placement, providing there's enough bone for implant stabilization. Absolutely, immediate implant placement is a indication. Now, how do we manage trying to maintain the buccal contour? First of all, I don't think there's much controversy in terms of we should graft the gap nowadays, put bone graft material in the gap. And in terms of how should we graft the gap? Should we just graft it right to where the bone level is, or should we do the dual zone? And thanks for Steve Chu and Dennis. I mean, they're really smart, innovative friends. And the dual zone technique, I think, works very well, based on under my hands. Not every case works perfectly, but I mean, I have some pitfalls here and there that the ridge the gingiva wasn't maintained as well as it used to be. But the reality is this: every time when we graft the gap, the graft material seldom just stay right at the bone level. We always have graft material that's sitting above it. So essentially, almost everything is dual zone. All right. So to put in a nutshell, if I'm going to graft the gap, it's pretty much like a dual zone scenario. Now, how about if we do not, extract the whole root and just put a root shield in there? I mean, I'm actually doing a research with that right now, and actually with corresponding with Marcus Hersler and Otto Schur. I mean, two very dear friends. And I mean, does it work? It works too, but of course, just like everything, it has its pitfall too, and we can discuss about it too. Of course, another way to maintain the buccal contour is to graft outside the buccal plate, either with bone graft or tissue graft. So again, just put it in a summary that, with those type of class 1 situation, sagittal root classification class 1, I would intend to go with immediate, because there's plenty of bone on the palatal area for implant stabilization. If I can, I would try to definitely graft the gap, and pretty much in a dual zone scenario, look into the possibility of grafting outside the bone with bone or soft tissue graft. That's where I stand on that.
And would you also look at immediately temporizing the case, or leave it with a Maryland bridge or an Essex appliance? Or?
Great question. For me, in my practice, for a single anterior tooth, I dare say over my career, more than 99.999% of the time, I end up doing provisualization. So when do I not do provisualization? In those extremely rare circumstances, that's when the implant is not as stable as I want it to be, and we can talk a little bit about what is the definition of stability. I mean, I have my own personal feelings about it, but those are the few rare cases that the implant's not that stable. I decide to leave it there. Then I say maybe I'm not going to provisualize it. But like I say, 99.999% of the time I end up provisualizing it.
There is a question, I believe that these days, what is your take on this tissue level implants into the end? Because peri-implant seal it plays a very important role. So, what do you have to talk about onto the peri-implant tissue development and maintaining so that we do not end up into a situation like mucositis and or peri-mucositis or peri-implantitis?
So tissue level implant, all right, versus bone level implant in the aesthetic zone.
Yeah,
Most of my career overall, I typically place bone level implant in the aesthetic zone. Posteriorly, I've done my share of tissue level implant. One implant that comes to my mind, tissue level, actually the two implants I've done tissue level over the years are Straumann, okay, and also the Noble Biocare, the perfect is almost a pseudo tissue level thing, set up implant. So what my feeling is that every time if I use a tissue level implant in the aesthetic zone, the struggle, I mean, and I'm definitely not an authority in tissue level implant, all right, but the struggle I faces is where do I put the platform of the implant in relationship to the bone, all right? And what that means is because most of tissue level implant have some sort of like a polished collar, right?
yeah,
And then, and on top, so that is one struggle. Where do I put that platform? Where do I put the smooth, rough junction? Do I put it, subcrestally, or should I put it ecocrestally? And if I do that, if I put the platform of the tissue level ecocrestally, the smooth, rough junction, the collar, and in my days, the shortest collar I have was what they call the plus, okay, aesthetic plus, which is I think 1.7, 1.8 millimeters. So my prosthetic emergent profile, I start struggling, at least under my hands. My emergent profiles are struggling. So I frequently start putting the rough smooth junction subcrestally. And the second thing I faces, at least under my own hand, with the tissue level implants is frequently the platform flares out. All right, there's a flare there. And then you all know, you guys publish beautiful book and you guys are expert too. Nowadays, we try to select implant for the sake of aesthetics that have a very narrow platform. So because of that, actually nowadays, just from my own personal experience, I usually stay away from using tissue level implants in the aesthetic zone.
yeah. Thank you so much because many people has this confusion that where to use these tissue level implants. Now, what about developing the peri-implant tissue? So, like a situation, if we see that there are two teeth missing in the anterior, maybe the central and the lateral. So, would you like to prefer placing two implants, or you prefer placing one implant with a cantilever situation so that you develop the soft tissue, the papilla, and the second question in continuation is how to develop the peri-implant tissue because soft
Okay,
tissue
so
is very important.
all right, so you talk about inter-implant situation,
Yeah,
regardless central, lateral, central. Well, especially central lateral situation, do we do an implant cantilever or should I put two implants in there? Based on my experience, I actually prefer to use single implant and cantilever. All right. Now, then does that mean the papillae is always going to be better when and we talk about between two implants, into the papillae between two implants versus the papillae between a single implant and a Pontic. If you read Garber Salama's publication, they obviously mentioned that when they measure the interproximal tissue is significantly greater papillae-wise when you have implant cantilever versus two implants, significantly, at least 2 millimeters. Under my hands, I don't find the same type of situation. I actually find that frequently the papillae between the implant Pontic is maybe just a tiny bit better than having two implants together. all right? Not that much better. And even if it is, it's less than a millimeter at most. Then why then do I still prefer putting an implant with a pontic then? Well, providing if the occlusal management is possible. The biggest issues when you put two implants right next by each other, you increase the risk of having a little bit more bone loss around the implants. Now, we can talk all we want about modern day implants or the newer system, newer concepts. I don't think there's such a thing as an implant out there with no bone loss. I mean, all implant systems are capable of having bone loss because it's not just the design of the system, it's not just having some concepts. It's just, you know, that there's a human factor, that's the surgeon's factor. Because of that, putting two implants right next to each other, you increase the risk of having some bone loss. And if you believe in the concept that the soft tissue follow the bone, so you put another implant in there, increase the risk of bone loss, then thereafter potentially increase the possibility of papillae loss. So that's where I stand on that. Now, the second question you asked about soft tissue development. And of course, regardless single tooth and multiple teeth, the concept is actually pretty similar. And nowadays, if I can, such as if I can do it immediate, I will do so because the emergence profile is there already. So we as a clinician, is just simply, our job is simple, it's just to try to maintain it. However, if it's in a hillside, tissue already collapsed, then we need to develop it, all right? So how do I attain the soft tissue that I desire? And first of all, I tell you, it's not that in my career, every single case I can maintain or develop the tissue perfectly. In many cases that it doesn't look so well either, okay? But patient's happy. I may not be happy because if I take a picture, I put it on the screen, some of the audience say, ooh, Joe Can's case is not so pretty, you know, but that's the reality. So to develop tissue, the key thing in my opinion, of course, providing the bone is good, I think soft tissue grafting is very critical, in my opinion. So in my practice, I actually do quite a bit of tissue graft. I want to make sure I have as much tissue volume as I possibly can, because you cannot develop anything without soft tissue if the soft tissue is compromised. So how much soft tissue do you need? I mean, obviously, the more the better. However, vertically, from a crestally, I would like to see minimally 3 millimeters of soft tissue. If I don't see that, if I see like 1.5 or 2 or less, I would like to typically do a tissue graft just to attempt. When I say attempt, and I'm sure you folks all know, doing grafting is not 1 + 1 = 2. That means if you put a piece of soft tissue there, doesn't mean that piece is going to stay there indefinitely. It will remodel. So 1 + 1, I'll be lucky to get 1.5. Okay, on a bad day, sometimes I get 1.3, all right? So, but tissue graft, at least in my hands, under most circumstances, at least more than 70% of the time, it do help to enhance the situation. Then how do I develop the tissue, the emergence profile then? As I say, in an extraction site, I usually try to maintain it with the provision, all right? And the most critical area, you know, like when you look at the Ernesto Lee and UPenn, University of Pennsylvania's publication, Ernesto is actually one of the co-authors. And what they stated is, you know, the so-called the subcritical zone and the critical zone. I'm sure you folks are aware of that. And the general rule is the subcritical area is the portion of the emergence from the implant platform to approximately 1 millimeter or so below the gingiva. That's called the subcritical area. And the general rule is this: we want the subcritical area nowadays to be with an emergence that is narrow and coming out like that, rather than just straight out, all right? And then they define the critical area. The critical area is the area between approximately 1 millimeter subgingival to approximately 1 millimeter supragingival. That is the critical, that area is, in my opinion, the most critical area the contour, to define the shape and how you want the ginger to be like. So, and there's no strict rule on that. A lot of times, this have to do with trial and error. So, in my hands, in critical aesthetic cases, I always put the patient on a provisional first and play around with the provisional emergence, both critically and subcritical area. And sometimes I may need to get the patient back and forth several times if I really want to get that case perfect, all right? And then once I get to that point, I will try my best to duplicate the emergence. So hopefully my technician, again, will try his best to duplicate what my provisional has. When I keep repeating the term try our best, meaning, unlike many times you listen to people lecture, people always tell you, go ahead and make the provisional you want it to be, get the gingival perfect. Then you do all this duplication, right? Fancy duplications, and then next thing the crowns come and the gingival is perfect. I'm in the midst of doing a little study right now. The study is like this: how easy is it for me to duplicate the emergence profile of the provisional that I make it perfectly? How easy is it to make it, I duplicate it, and the lab make me a crown and I put it in there and everything matches perfectly. Surprisingly enough, how often that means if I make my provisional, get the gingival perfect shape the way I want it to be, then I duplicate everything, send it to the lab, come back to the crown, and my lab technician is really talented, okay? Come back to the crown, put it in, and I take a picture again and look at the gingival shape and the level compared to my provisional and the new crown. Guess what? More than 75% of the time it doesn't match. And so for me, if I want to make it just like my provisional so I can take a picture to show the whole world what a great clinician Joe Can is, I will typically go in there and start having the lab adjust again, or I put some composite to reshape it, to add on to the porcelain so the lab can reshape it again a few times. To be honest, most of my so-called showcases that I need to lecture on a big India podium, so everybody say, wow, Joseph Can, your work is amazing. I typically need to reshape my final crown probably on an average 2 times before I get there, so I can take that picture and everything looks perfect. So to put it in a nutshell, getting the so-called perfect emergence profile is not so easy. It takes a lot of devotion playing with provisional, regardless in immediate or heel size. But one thing, if you believe in God, God is very fair, okay? Because most of our patients, actually, they don't notice most of the time. They don't need the ginger to be so perfect that you can put it on the screen, nobody can tell the difference. Most of my patients, actually, I do that mostly for myself more so than what the patients eat. And I have some really, really picky patients, trust me, from Beverly Hills, from overseas, they're flying in and still, they don't demand that perfect, that level that I put on a big screen, like what I show you on the screen here, like this type of situation. They actually don't demand that. It can be much less than that, and the patients are already very happy, pay the money.
Thank you. Also, I remember our discussion in 2011 at the ICI Korea conference when you were in a hurry to catch your flight, and we spoke in the hotel lobby regarding the jumping distance, and we discussed some different graft materials and what is your treatment? Or you want a xenograft that's going to stay there forever, or you want a fast resorbing TCP, or you want an allograft, because a lot of people have their own reasons for using different products. It could be any reason, as we all know. But what would be the last so many years, what would you say? And a lot of them say 50-50%, 70-30, 80-20. It's a very random figure. Nobody can actually, like they say, we load it between 4 to 8 months. So is it 4 or 8? So it's too much of a time difference. If you say 4 to 5, it's understandable. I heard somebody say we loaded within the first 3 years. So 3 years, I mean, it's a long time. So what is the kind of graph would you use if you want to load your patient with a provisional and call him back straight for the impression and for the final process? Your own choice, your preference. Everything can work, we know that. But.
Absolutely. So again, we talk about immediate situation. What do we put inside the gap? And then how long do I wait? In general, like you say, there's many philosophies out there, and there's no one perfect philosophy. For me, I don't go to, okay. Even for me, I'm not that critical. But one thing I've learned, we did a study. When we put bone graft in the gap in immediate and immediate situation, put bone graft in the gap, one group we just put xenograft, the other group we just put allograft, small particles. And then we look at how much the facial contour collapses in comparing the two groups. Well, probably not surprised, the group with allograft collapsing more than the one with xenograft. All right, so conclude with xenograft, it's just sitting there most of the time. Most of the time, it's like a piece of rock just sitting there, maybe to help. It doesn't mean that xenograft doesn't resolve. We all know that, doesn't remodel, okay? But then it just remodel much less. It's just like when we do a sinus situation, when we do graft in the sinus, if we use 100% xenograft versus 100% allograft, and if you measure volumetric changes wise, we notice the group with allograft shrink down a lot more, all right? So there you go. So what do I do? I mean, maybe it's old habit. I have this tendency of thinking, all right, xenograft, osteoconduction and allograft, maybe a little bit of induction, maybe, if there's any. So let's do a mix, all right? So for me, I always, through my training, I always just say, give me a 50-50, all right? But the reality is, do I truly get 50-50? Probably not, because it depends on how the nurse will mix it. And then also, volumetrically, allograft, the 1 gram of allograft volume-wise is actually very different than 1 gram of xenograft. You know what I mean? So whenever people, even my dear colleague and my former dearest student, Istvan Urban, sometimes, we'll talk about 50-50 autologous bone, and xenograft, When I ask, I mean, can you ensure you really get 50-50? I mean, it's hard, but for me, just put it in a nutshell, to control the gap, I always graft, and I typically use small particles, xenograft and allograft 50-50 graft into there. In terms of your question on how long after such as a single anterior immediate implant placement and provisionalization, how long do I wait before I make definitive impression? Again, there's no strict guidelines to it, but for me, typically what I do is I start making my definitive impression for the fine ground at around month number 4. Okay, month number 4, well, between 3.5 to 4 months, providing when I place the implant, the stability, and I want to repeat again, and sometimes we may want to bring out how do we define stability, but if, in my opinion, the implant is stable enough, most of the time, 3.5 to 4 months is good enough for me to make my definitive, impression. And then the final restoration will be placed on probably around at month number 5 plus or minus.
All right. Thank you very much.
I don't wait for 3 years.
All right. Yeah.
Please don't make me wait 3 years. Yes.
Yeah, we hear a lot of different opinions on the stage and in social media. People are affected by a lot of different techniques. Well, I think whatever works in one's hands, one should stick to that.
That is the perfect point right there.
If you can reproduce the result constantly, I think you should stay. Because
absolutely
a case report is lowest on the evidence scale. We know that, but sometimes you do some things, you get a better result than you expect, and sometimes you do everything very well and then it just fails for no reason. Sometimes you just don't know.
You are right. And I still have failures. Even now, I still have failures. My dear friend, I still have failures. All right? Don't think I have all the magic bullet here. All right?
Yeah, same. The only bullet that we have left is the last one.
Please don't do that. Please don't do that.
One more important thing which we discussed a couple of times is altered passive eruption, which is, you had shown that lady who came from India to you for treatment from Bombay, the anterior case, that young lady whom you followed up for, I think, 12, 13 years, which you showed us in Sevilla. So what was your take on the prosthesis? Would you keep them on a young girl who's 20, you place 2 central incisors maybe, or just 1 central? Would you like to load them provisionally and leave them for a long time? Or what is your take? Because we see this very often now. All our old cases, which are coming back after 18 years, 19 years, you know, maybe even more, 20, 21 years when we started doing it, we definitely see a little difference. And sometimes the patient is not even, like you said, where the patient is happy. They are not concerned, but they come in for a routine recall, and we have to take a photograph to put on on a slide on stage and look very good. So we tell them that, you know, it's like kind of it's moved, and in layman's terms, not that patients usually care, but sometimes it is, if you have a high smile line, it looks a little odd. So what would you think, I mean, your latest research on delayed eruption and passive eruption, what is the best way you think we can counter this? Because we are going to see a lot of this over the future. And as more and more people are placing implants, so you will see a lot of this. Is there a foolproof method? I know there is no thumb rule for anything, but is there something that you can guide us with your experience and vast research?
This is a great question. And I guess whenever after you place an implant in the aesthetic zone, down the road, as you follow that patient up, if you see a discrepancy, maybe sometimes the crown becomes shorter, intruded, or sometimes, the position, there's a gap develop, or maybe sometimes you see a recession, all right? So every time when you see gingival, let's talk about the gingival changes first. The gingival changes sometimes is typically because over time, wear and tear, because you know that even on natural teeth, we can have a recession over time too, right? Sometimes it's iatrogenic because the surgeon placed the implant wrong or the prosthetic is over contour. Slowly, it creates a gingival problem. In terms of the crown shape, the position being changed, sometimes it's because simply other teeth, due to, teeth got drifted, and then the implant stay put. That's why we create that problem. And sometimes because of patients is still growing, and the implant serves like an ankylosed tooth, and the rest of the teeth are still moving, and the tooth becomes intruded. So, but basically from the one that we cannot control, well, the one we cannot control are typically when adjacent teeth are being shifted, that's life, right? And then, or maybe over time, because the patient wear and tear gingivals are changing, that's part of life nobody can control. But what we may be able to control, and what we learn a little bit more nowadays, is what is the minimal age that we can safely put an implant to replace the patient's front teeth. Now, years ago, honestly, I have no idea. I read the literature just like all of you. They say, well, we want to wait for the patient's growth stop. So, maybe between 16 to 19 years old, depends on the gender, right? And maybe you take hand x-rays or things like that. And honestly, how many dentists in the world really knows how to read a hand x-ray, okay? But the main point is this: even despite following those rules, many of our patients that we place implants when they're like in the mid-20s, or sometimes even late 20s or 30s, years afterwards, we find out the crowns got shifted. So what we notice is that, I will refer to my friend like Odette Bahad, wonderful periodontist, lecture on the stand up on the AAP podium, telling everybody that, patient's growth doesn't stop. When you're like, when you think that you're 23 years old, your growth is stop, it doesn't just stop right there. There's still a lot of some delayed growth. And we learned that especially for the female group, more so than the male group. So therefore, even, I think I discussed with, you folks before for female patients, I noticed in my practice, many of them over the years, when I replace a anterior tooth implant, there's some movement of the implant. That means intrusion, maybe some recession. So can we do anything about it? Well, so this is where I stand now. I don't think there's an absolute magic, I'm going to use the term bullet again. I know now I'm not going to put an implant when a patient is, 20 years old or less. Absolutely not, regardless gender. That means male or female. I will wait. For male, once they get past 20 years old, at least from my data, my clinical experience, I don't seem to see too much problem. And you may agree with me, most of the problem is the female situations when we put implants in them. And so what I deal with on the female patients is I am very hesitant nowadays to even put implants in, or I should wait at least when they're probably at least 23, 24 years old, if possible. I mean, some situations you have no choice, but if I have a choice, I try, and I heavily consent my patient, make sure they know, their parents know the consequence, that there may be a chance, or maybe a good chance in their lifetime, even if the implant survives, they may need to change the crown because of that thing. And also I'll put the patient on some sort of retainer in lieu hoping that will slow down those kind of problems or prevent those kind of problems. And the main point is this: if the crown get intruded a little bit, changing a crown just costs some money. Most patients, as they age, they can accept that if it's really a problem. But what concerns me, if we have a situation in which we have a significant gingival recession, now that becomes a little bit more daunting for all of us to try to reconstruct. As you've seen, I show you some of my cases, it's like a labor of love. And some patients, they may not even have the money to pay us to do those kind of procedures. So, but what I believe is this: the longer we wait, especially on the female group, we wait by putting implants in, we minimize the chance of that significant recession. All right, so that's where I stand. So to put it in a nutshell, I try to wait till at least, for female patients, 23, 24 years old, and then consent the patient, make sure they're aware of it. The longer I can wait, the better, because implant is not, unlike most people believe, implant is not like forever. Is that magic bullet that it will just last forever and no more problems? Because we all see peri-implantitis. We all see the problems.
That's true. Thank you. Thank you very much for an honest reply as expected from you, because this is what a lot of people are in wondering, should we start placing implants when the patients are 16, 18, 20? So also coming to this, a very honest question from the heart, that which are the situations where you would, okay, we have soft tissue grafts, we have alloderm, we have mucograft, we have FGG, CTG, we have everything at our disposal. When is the only situation you would look at lab bailout with pink porcelain in the anterior zone? If it's a single tooth, would you attempt pink porcelain for some reason? If it's a full hybrid, it's okay. But if it's like one central, maybe big defect, would you want to? Because we see sometimes the same patient. I don't know if these patients come in courses or they are private patients, because in 21 years of implant practice, I have seen to tell the patient to undergo repeated procedures, to do a bone graft, a soft tissue, wait for 6 months, again a bone graft, soft tissue. It doesn't work, it exposes for some reason. So multiple procedures, nobody likes it. Nobody likes it. So where would you maybe give, let's say, only one instance where you would use pink porcelain to get out of that situation, patient is happy. The lower lip line, of course, is fine. A thick lip is okay. But if you think, all right, this is enough, the patient has had enough, and they don't want any more surgery.
Great question. I think this question and the root shield question, maybe we touch on a little bit more later on, those are great questions. You know why? Because when we talk about GBR, Obviously, you have a patient with a defect, right? Not just a tiny defect, but a significant defect. The question is, when do we say, all right, let's go pink Paulson, or should we even give that option to the patient, or do we just graft and graft and graft? Then why did I say this is a great question? Because if you look at social media, you look at lecture circuit, I mean, we have a lot of big superstars on bone regeneration and soft tissue regeneration. People can grow papillas, people can grow bone 12 more meters. At least under my hands, I cannot grow bone 12 more meters vertically, not for me, okay? But have I tried all the different techniques? Yes, I've tried all the different techniques. I tried, the Fort Curry bone plate, my dear friend, Dr. Curry, talented. Okay, I've tried the sausage technique. I make my own special Chinese sausage. Chinese sausage technique. Okay? And then from my dear friend Yusuf Urban. And then like all the things from Jovanovic, Simeon. All the great GBR people. And the thing is, GBR is kind of like a mythical thing that I think it works for some people consistently, but under my hands at least, and I look at a lot of the colleagues I work around in Los Angeles or elsewhere, the success rate doesn't seem to coincide with the great bone grafting artists. So
exactly.
So maybe it's just because, I'm sorry, yeah,
that's right, yeah.
So,
go on.
Yeah, so maybe it's because it's so technique sensitive. Even if I read their book, I follow them, I take their course, and yet somehow it's not so simple. And even with that, in my experience, there are some cases that I'm able to regenerate bone, vertically, looks really great. And then I put the implants in and I take the pictures, I document the case, looks beautiful. I lecture with it, everybody clap their hands. And long and behold, such patient come back 10 years later, with a big bone loss, and so is it because the implant has a problem, or is it because my graft has a problem? So I face a lot of that. I don't know whether my Indian friends experience some of that. I'm sure you may have seen some of those too.
Yes.
So because of that, I know what I do is whenever I look at a patient with a defect, I always tell my graduate student that treatment planning, giving a patient treatment option, is what I call risk management. That means it's our duty as a doctor, as a dentist, is to try to do a procedure with least amount of risk, but maximum amount of benefit for the patient. And unfortunately, a lot of times, those significant vertical GBR or try to regenerate papillae, those are high-risk procedures. The benefit, a lot of times, unfortunately, we know is not there. And so I look at the risk of the situation. And by the way, my students always tell me this, they want to, the patient want that treatment. The patient want the GBR. But I always tell them, and maybe you agree with me, whenever we have a situation, we always provide the patient treatment option A, B, C, D, whatever. However, most of the time, the treatment, the patient end up saying, you know what, I want treatment option D. Why do you think that patient wants treatment D? Now, sometimes it's financially motivated, but put aside the financial part, I always tell my graduate students and the young student, a lot of times the option the patients end up treating, whatever you have presented to them, is the one that we as a doctor try to push for. You understand what I mean? I wanted to do that way. I'm going to just give that patient that little bias there. Oh, that is the best way. Now, why do I do that? Sometimes because I need to take some picture, document the case, because I need to lecture on the AAP or the AO or ACP podium. Oh, Joe can have done this. Or maybe because I am more experienced in that option. That's why I push the patient towards that direction. Or maybe sometimes it's because for financial reasons too, right? So there's a lot of motives. And I'm not saying that doctors are not good people, but doctors is just a title. In the end, is the core value of an individual human being. All right, so those factors affect us a lot. So going back to the GBR situation, for me, I know, all right, I look at the limitations. I know, let's say in a single tooth situation, how much interproximal bone there are. Where's the interproximal bone? Because we know that's going to define how much we can regenerate vertically. And then, like how's adjacent teeth condition and all those factors. And if after I analyze everything, I know that by doing GBR, the chance of building the patient's tissue back to its original condition is going to be very remote. Okay, I may suggest the patient, we can do one try, and then if it doesn't work, then we probably call it a day and go pink porcelain. So many of my cases, I do pink porcelain, many.
I have a question. That as we see Professor Boozer, Daniel Boozer, he advises now the late placement. And so what is your take on immediate placement, late placement, delayed placement? So would you prefer doing a late placement by allowing the soft tissue to heal on and the site has to heal on, and then you do the re-entry? Or when we go immediately, are we preserving the bone and the soft tissue, and with the temporization immediate, it makes the future prosthesis much more better? So what's your take onto this?
Just like I mentioned to the audience early on, very early on, immediate versus early versus delay, I done all of those procedures. I still do all of those procedures. And what direction I go depends on the patient situation, all right? Because there's an indication for each one, right? So I don't favor one procedure. If that case is indicated for early, I will do early. But if the case is indicated for immediate, I will do immediate. Now, does that mean immediate is better or delayed or early is better? Actually, I believe each one has its strength and weaknesses. So let me just put it in a nutshell. Let's say immediate. If the tooth has pus coming out, big infection, no buccal bone, there's hardly any bone for implant stabilization, do you think it's a good case for immediate? Absolutely not. I will go delay. Now, the benefit about immediate, I always say for immediate provisionalization, that is, if you look at from a soft tissue standpoint, I like to call immediate good for the papilla, but if there's anything ever goes wrong, is the facial tissue. In other words, if you were to do immediate tooth replacement, putting implant in there, you need to put a provisional in there, because of the placement of the provisional right at the time of extraction, the provisional help us to protect the papillae. Therefore, you seldom see a significant retraction of that papillae unless the patient have a severe underlying periodontal condition to begin with. However, if there's anything that ever goes wrong, is facial tissue. Sometimes we get recession, sometimes the facial tissue get collapsing, and that's why now you see the Salamas, a dear friend also, Dr. Glickman, Howard, excellent clinicians, Hersler, they all talk about the root shield, right? Because the goal is, by doing that, you minimize the tissue problems, So immediate, in my opinion, traditional is good for the papillae if there's anything goes wrong with the facial tissue. Now, when you look at early and delay placement, the concept of the soft tissue is just reverse. What that means is this. In general, when you do early and immediate, when we look at the soft tissue, typically it's actually pretty good for the facial tissue, but if ever there's anything that ever goes wrong, is the interproximal tissue. Now, why is that? Because if you do a delay procedure by doing bone grafting, tissue grafting, waiting the facial tissue to be stable, putting an implant there, the soft tissue facially usually seldom shrink back that much. Not that much. There are some cases, but not as much as immediate, because the healing factors is gone, it's done. However, because of the lack of support to the interproximal papillae, and especially when we do early implant placement following the publications by Danny and others, when we do the contour grafting, when we make that double vertical releasing incision, encompasses the interproximal papilla, and we all know, when we reflect the flap, including the papillae, does not always mean we're papillae loss. However, you increase the risk slightly. That means if you do, let's say, 50 cases, you refract the papillae, you will bound to have a few cases that the papillae get compromised. And one last point I want to put together on immediate versus early, especially. What I notice, at least under my research hand is this. If I have a patient, the front tooth is failing, I look at the dynamics of the soft and hard tissue around that tooth, and I found out that that is not a good case for immediate. How so? For example, because of big infection, there's no bone at all. There's no bone buccally, there's no bone apically. Because of that, you cannot even get stabilization. So there's no buccal plate, no apical plate, or maybe the case is not good for immediate because the root is way too long. It's just so long that the implant doesn't reach deep enough to engage it. All right. So I say, I'm not going to go to do immediate. Let's do early. That means I'm going to extract the tooth first, and then no bone graft, wait for 6 to 10 weeks for the soft tissue to close. Then I open up the flap and I do implant placement. What I notice is, if the case is not good for immediate under such circumstances, more than 75% of those cases, if I decided to do early, when I open the flap, I cannot do early. You understand? Just like I described, if there's no bone at all, apex, there's a big infection. If I decide not to do immediate, I decide just extract, clean it up, close, wait for 6 to 10 weeks later. When I open the flap, what do you see? Most of the time, you see a big hole there. That's my experience on that.
Now, my question is that I would like all the audience who are watching you right now on live on Facebook, they would like to know about your Kahn's classification, why it is so important, and after that, Tarnows, the 5 mm rule, so that when you are dealing with the anterior aesthetic zone, these two things are, I believe personally, that they are very important to take into consideration. Your classification and Tarnows 5 mm rule, so that the papilla creeping, it gets affected because of the bony peaks.
Okay, so first of all, my dear friend, I really appreciate you say so many nice things about me, like Kahn's classification. In my humble opinion, I have no intention of naming anything under my name, any classification, because honestly, in dentistry, whatever I do, the idea somehow has stemmed from the great periodontists, great prosthodontists, great maxillofacial surgeons throughout the history in time, okay? I am just maybe modify things a little bit, and so for me, I really cannot put anything under my name. I publish a little research. I mean, it's just because, oh, I found out this is it, but then it is what it is. So I don't really consider it is like Kahn's classification. But for the sake of discussion, the sagittal root position, and then I see there's another paper being published on that too, like from the Glickman group and from a group in Hong Kong, James Chow and other people have done, similar things that they should be getting recognition also. But the main point is this: I guess what that teaches clinicians out in the world, if they were to do anterior implants, first of all, CBCT nowadays widely available is extremely, extremely important, right?
Yeah.
And then it also gives us a tool that, all right, by looking at this, we should look at how the root is being positioned so we can plan the case a little bit better. All right, that is the main point on that classification. Now, in terms of Dennis, Dennis is, in my humble opinion, one of the greatest legend, okay? Legend, definitely like him, Danny Bills, and all the absolute legends. So when Dennis published that article, I believe in J. Perry, 1992, okay? Just a 2-page article, but the impact is strong. Why? Because it gives us an idea that, oh, at the interproximally, the bone serves as the foundation of the interproximal papillae. And if the bone is there, the papillae, from a theory standpoint, should be there. And we also understand now, okay, there's a limitation. That means soft tissue, on an average, is going to be approximately 4 to 5 millimeters sitting above the interproximal bone. So that article is even more powerful than whatever I have ever published, because it gives us and quantified us the limitations of soft tissue. So therefore, I want to maybe give you a question to think a little bit, or the audience to think a little bit. So based on like people like Dennis, say 5 millimeters from the bone, and then the contact area, it impacts us about aesthetics a lot, but it also teaches us there's a limitation. There's this thing when we treat patients called the biology, all right? Because nowadays, I think most clinicians feel that the technique that we learn from whoever, the whatever technique or the instrument we buy from whoever, that can override biology. What do you think? Can we override biology?
No.
I mean, I am, whatever, this is my arm like that. I lift weight every day and drink a lot of proteins. Can my arm be suddenly 2 times the size? I'm 5'11". I want to be like Michael Jordan, 6'6". Can I just stretch myself and suddenly I become 6'6"? I mean, that's this thing called biology.
Yeah.
So what that means is this: I want the audience to think, when we, let's say, interproximally, if what Dennis say that the soft tissue is 5 millimeters, normally, most of the time, there are exceptions of the rule, of course. Most of the time, it's 5 millimeters above the interproximal bone. So if we go in there, maybe tunnel a piece of sashimi underneath there, my favorite food, sashimi, also known as connective tissue graft, tunnel a piece of sashimi in there. Do you think suddenly I can make the papillae from 5 to become 8 millimeters long?
No.
What do you think? Okay, and if we did that, we take a picture, it looks beautiful, and everybody clap their hands. What do you think will happen to that piece of 8 millimeter tissue if you wait around 6 months later? Don't even need 3 months, 5 months, just 5, 6 months later. What do you think will happen? Because the biology is going to take hold. Therefore, let me tell you something. If there's young students out there across India, they have inspiration to be great dentists. All right. Let me tell you, dentistry is not a show. All right. Medicine is all about respecting the biology and treat the patient as a human being, not a lab rat. All right. So we must understand that biology. All right. And the greatest clinicians are the ones that not only they respect the biology, but they understand the biology. Only by understanding the biology, we as a clinician understand our limitation. That means, what is the limitation of that case there? Without knowing biology, we thought we are God. We thought, oh, I just use this technique, that technique, use that instrument, power on, it's going to be great. Everything's going to be perfect. We can recreate another human being. It doesn't work like that, my dear friend.
Okay. Can we ask one more question, or you would like to?
You can ask one more question.
Okay.
Absolutely.
Okay. So now there is a lot of talking about socket shield technique in anterior aesthetic zone. There are 2 school of thoughts. One school says no, we would not like to leave anything inside. And then the other school says, because this technique was created by Otto Zur and Herzuller, Marcus. So they left it, and then now back again.
This is a great question. And first of all, I want to tell the audiences this, okay? I mean, as I get a little bit more older in treating patients, that means having a little bit more experience in treating patients, I've learned not to criticize things as abruptly as I want to. That means, when I see something new, just because it's new, I don't put it down. You understand? But on the other hand, I also need to understand that I must approach it very cautiously. All right. Why do I say that I do not shoot down anything that's new, any technique, any concept that's new? Because the reality is this: in dentistry, you and me have been practicing long enough, judging by the little hair we have, that we know that a lot of things work. A lot of things work. Okay, like root shield. Have you done root shield? Does it work? For me, I have done it and it works. All right. But does that mean that I'm going to just be reckless, just going? No, I'm not going to do that because there's a lot of unknown factor. I don't know what is the long-term outcome still, despite people say that, okay, they publish this retrospective study, this and that, a lot of data. I know. Okay. But does that mean that it totally defines it? No. We still are, every case is a learning experience. Just like even now for me, when I do an anterior immediate implant placement in the traditional way, I still approach it with lots of respect and reverence. It's not because, oh, I've done it 20 years, I am God, I just know how to do it and it's going to work. No. So, root shield, where do I stand on it? I've learned a lot from, Salama, Hersler, Glickman, the list goes on and on. Mirtas, all those great clinicians. I mean, they're just amazing, right? And I'm just here watching them operate and learn a little bit, pick up a little bit so I can be better at it. And in my opinion, at least under my hands at this stage, and I'll tell you, I'm doing some research right now. I told you, I'm doing currently a research with my team and Hersa and Otto together. We're doing a research right now, and we're in the middle of it on root shield. And of course, we're doing some other study too, like my dear student, Joey Chen, another really talented surgeon. I mean, amazing, all right? And we have published some paper on it. And so far, they work with some complications, of course. And what type of complications, such as root being exposed, all right? Both internally, externally. We have a couple cases, the root got infected, and we end up needing to re-enter the site and try to remove it. And in the meantime, afterwards, we end up losing significant amount of tissue. So to put it in a nutshell, people try to do those procedures, root shield that is, they either try to maintain the facial tissue or the papillae between implants. Now, in my humble opinion, this is just my opinion, okay? I think that is a very technique-sensitive procedure. Even when I'm doing it, I do my share. Every case for me is very technique-sensitive, all right? And of course, besides case selection, selecting the right case, that's one thing. Because most of my patients come in with tooth failing is because of severe endo problems, severe perio, or combined perio-endo issues. I seldom have patients just suddenly fracture a tooth like that and say, okay, I come in, I need an implant, okay? So besides case selection, at least what I believe, if you were to keep a piece of root on the facial aspect of the tooth, the goal is to maintain the soft tissue contour and the soft tissue apicoronally. Root shield definitely will work perfectly, without a doubt. However, I want to ask you two questions.
Yeah.
Number one.
Yeah.
How critical is the patient to the patient that the facial contour need to be 100% perfect? I would dare say that even my practice, a lot of interestingly demanding patients, probably easily 65% of them is not going to make any difference. And they won't even know. They won't even know. You only know if I take a big picture, put it on the screen, then you say, oh yeah, Joe, can that thing collapse a little bit here? Yeah. Second point, all right? Second point is that if you look at our cases, when we do traditional immediate implant placement provisionalization by doing the dual zone grafting at the gap, I mean, maybe tunneling, doing another tissue graft like my dear friend Sukeli or Otto Shu doing that really nice, beautiful job on the tissue graft, and then maybe with some bone graft. A lot of those cases look beautiful. I'm sure, I have that too now. Of course, I have some cases that's not perfect too, but it's not unacceptable. So those are the 2 points. Now, how about interproximally? Interproximally is a totally different beast. Because, what I mean, if you have 2 implant right next to each other, I can do all the bone graft I want. I can tunnel all kinds of sashimi underneath that papillae, but that papillae will still be compromised. So now for me, in my opinion, just my sole opinion, okay? Don't shoot me if I'm just my own opinion. If I have a patient, high smile line, aesthetically demanding, and then there's 2 implants right next by each other. And then if the condition of the root, one of the 2 roots, periodontally, root canal endodontically is sound, it fits within the criteria, then that is a situation that I do not hesitate much to offer that as a treatment option with the patient. Of course, bear in mind with informing very carefully consent to the patient so they understand the potential risk, because nobody truly knows. I mean, all these cases so far looks pretty good, but nobody is going to know that what will happen, because as we all know, even if I put an implant in healed sites, we can get peri-implantitis on that implant, right?
Yeah.
So now, when we do root shield plus an implant, even the shield is going to last forever. But can you guarantee that implant will never have any peri-implant disease? And if that implant, long and behold, have peri-implant disease, now you have a shield to deal with, things start getting a little bit complicated. And if you need to play with the shield, suddenly maybe the aesthetic will become really like a tragic outcome. I don't know.
Yeah.
So for the young students out there, I mean, never look down and criticize on something new. Always put a lot of hope in it, but yet I advise approach it extremely cautiously, just like anything else in life. And if you do that, because in the end, it's for the patient. It's not for our benefit. It's not because, I want to take that picture and show off on the screen or put it on Instagram or Facebook, whatever. I mean, that has nothing to do with anything.
Yes.
Because medicine is all about taking care of the patient, with that patient being the #1 beneficiary.
Yeah.
Not because Joe can want to be famous or Joe can want to lecture or Joe can want to show off. Has very little to do with it.
Yeah, thank you. Thank you so much for the honest answer. One small question again, and I think you are okay with
It's okay. Yeah, go ahead.
5 minutes. Yeah. What about because I believe this socket shield technique. I was listening to Daniel Baumer in University of Bern, the third international symposium organized by Professor Daniel Boozer. So he had a histomorphological study along with the implant. That was like very rare to get a human histomorphological section with the implant. So it must have been coming from a dead person or something like that, because in live you can't do that. There he showed that there was no bone in between the shield and the implant gap which was there, and it was more fibrous union over there. One thing. And another thing is that which will be later taken by you, that when you are doing an immediate placement or delayed also, uh, what you have to tell about the bundle bone. Would you like to scrape it out because it is going to resorb within 6 to 8 weeks? So you just don't want any high osteoclastic activity inside your bone remodeling, which will happen. or you will just leave it because it is very important? So these two questions.
Okay, so first of all, address about the histology issues. So when you mentioned about the histology, that's coming. The histology was from Dr. Buser's group, right?
Yeah,
Is
yeah.
that right? Yeah. So, but of course, I'm not sure that we can totally, you know, say that or deny a procedure based on one histology.
Okay.
We all know that. Because there's so many things that we don't know about the situation. I don't think personally I can make or break the procedure whether I decide to go or not go on a procedure based on one histology. I cannot do that. Okay, but of course, human histology also tell us something too. Where do I stand on that? I think that there's always a potential risk. All right, whenever you introduce another piece of root fragment in there, but so far clinically, it doesn't look that bad. I mean, I look at most of my cases. I mean, I have my longest follow-up. I mean, God bless the patient it's more than 9 years. It's more than 9 years. I first did that almost right after I listened to Hersler on the podium. I say, oh my goodness, this is amazing. I want to try it, And then and I have 9-year follow-up on that patient, and there's a lot of other patients have quite long follow-up too. And clinically, you cannot deny the amazing result. Now, histology-wise, biologic-wise, that's something that we need to, ask ourselves a question. Now, people often say that we should leave, the implant should not be touching the shield. I've done my share, and trust me, I don't think I can guarantee you that every single case my implants are touching the shield. I cannot guarantee because there's so many things that is dark in there. I can put all the lights in there. I mean, it's very challenging. All right. So point is this. I am not again going to deny the procedure based on one or two histology. Just like on the other hand, same thing for the group that say that, root shields are great based on a couple of histology there. I tend to be pretty neutral, those kind of things, okay? And then I need to observe, I need to try it on myself. Even with so much try, I would say that it's very technique sensitive under my hand still. After now, I have almost 9.5, 10 years of experience now. And but of course, there are better technique being published. Like I say, you look at I keep referring to Howard Glickman. I mean, he done so much work on it, and then I know he keep publishing on it, and he just gave me his special drill kit, which I really appreciate. So all those instrumentation will help, but still, it is not for everybody. And sometimes I cringe a little bit. When I see a lot of clinicians out there doing full arch shield because they need to do it all on four now. I mean, if you do that, don't shoot me down. I'm just saying I cringe a little bit, okay? Because I just say, oh wow, it's just. I mean, you got to be so much technique savvy to be able to achieve those type of things. I mean, I cannot do it. I cannot do it. Okay, so that's the root shield thing. Now the thing that you're talking about, the bundle bone. For me, if I'm going to do an immediate implant placement in the aesthetic zone, once you extract the tooth, even with minimal scraping, the bundle bone probably got disturbed already. The buccal plate, unless it's really thick, it will probably remodel. And because of that, it teaches us, I believe, if we have an aesthetic case, and bear in mind we're not doing root shield here, to try to get the contour to look right after immediate implant placement, besides grafting the gap, bear in mind, assuming that the buccal plate will remodel. All right. Therefore, now I will always either do tissue graft on the outside or a combination bone graft, tissue graft, a combination of those. And despite that, I still see cases sometimes that the tissue collapsing a little bit. But the main point is this: I'm not going to be too aggressive scraping the bone, the buccal plate on the inside, because I don't want to damage it. Now, of course, if the root has infection, I need to really clean it out, of course. But still, we got to be very, very gentle to it. So that's where I stand on that.
Yeah, and so what I believe is that there is a great saying by Buddha that nothing is permanent in this world. nothing is going to be permanent. So as you said, and you always accept it humbly, because I have never seen anybody in this implant world to be so humble as you are. You accept your the faults which has happened, and so the takeaway point from all of this, the discussion which happened almost an hour, that if you want to learn something, if there is some new technique or something, whatever you are trying to be on the patient, you have to learn it first. Get
Yeah.
yourself trained by the masters, and then perform it on the patient just by looking at somewhere and somebody has done it nicely, doing it straight away, going on to your patient and experimenting, as you said, that your patient is not somebody like a rabbit or a dog, and where you just place some implants and some graft material and induce. So anterior aesthetic zone, we talked about this graft material. So as you say that you have to choose judiciously where to, how much a composite graft material or allograft, and then contour grafting, as Professor Daniel Boozer says, that I just don't want the outer layer to convert into a uh, uh, homogeneous bone. You just want to maintain, and I have seen amazing results, 10, 5, 10, 15, 20, 25 years, 30 years, no changes.
I agree. I agree. I mean, and what you say is absolutely correct. Nothing, first of all, nothing lasts forever.
Yeah,
We will not be on this earth forever, too. Okay.
yeah,
So the reality is you can be the most famous superstar in the world. I mean, one day it's going to be over, too.
yeah,
So, and then really, I mean, every time I look at what I do, everything I do is because someone has inspired me. I had got that idea from somewhere. I don't think I'm so great. One day I just wake up, I can have all this fancy thing. Because of that, um, when I remember that when we swear our oath to become a doctor, the oath is not, there's nothing in the oath telling us that we need to be this famous person that we make so much money, we need to be well known. None of that. It's just a matter of relieving the patients from suffering. And in my humble opinion, the name doctor means the servant for the people, servant of the people. So something for me, I always think a little bit about, and it's not about whether humble or not. It's just I understand. I mean, there's no such thing as perfection. We try our best, and medicine should not be glorified, in my humble opinion. But it's just me.
yeah. Thank you so much, sir, for your uh, absolutely out from the heart opinions, and definitely my idea was not to say that this technique is good or that technique is not good, bad. I just wanted your opinion about that. What is this? Is it working? So the inference is everything we are doing. We are getting inspired by somebody, and then we try it. But as because I have been trained by Shasha Jovanovic and Istaman Urban initially during my guide thing, and I have seen Sasha Jovanovic. He's always, he gives stress on that you learn first, learn it,
Absolutely.
and then go on to your, as you said, your patient is not, you have to see that if you are doing something on the patient, would you like to do it on your relatives, on your mother, father, wife, children, and if you have this thing in the mind, you will never ever go for anything which is like an experiment. So, thank you so much for being with us for such a long, almost 1 hour, 15 minutes. and we all with our team. Lanka has some Wi-Fi issue, so he just went off. So he called me up that uh, ask him that I'm so sorry that there's some technical issues. And my team is here, Dr. Govind Jha and Dr. Vaibhav Gupta. He's a very young, these are, and Chakshvesh is not here, Dr. Deepak is not here. They are young dental surgeons who are trying to learn, and we would love to see here in India someday. And thank you so much. My regards to you. I'm so thankful, and for on behalf of whole of the Indian dental surgeons, that you gave your precious time and came down and gave us your word of wisdom. Thank you so much. Thank you so much.
Well, thank you. I want to, send my regards to all my friends in India, all around the world. And then I'm grateful that I meet you guys, and I'm sure this friendship will last for a long time. All right.
Thank
Thank
you
you
so
so
much.
much. Have a great one.
Yeah. Thank you. Bye bye. Stop it.